Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Hello, everyone. My name is Dr. Brian Hoh, and I'm a neurosurgeon, and I'm the chair of neurosurgery at the University of Florida.
And my name is Nerissa Ko. I'm a neurointensivist and vascular neurologist at UCSF Medical Center in San Francisco.
We are excited to be talking about the American Heart Association and American Stroke Association's updated guidelines for treating patients with aneurysmal subarachnoid hemorrhage. This is a big deal because it's the first time these guidelines have been updated since 2012, and the information in them can truly save lives.
As someone who takes care of a lot of aneurysmal subarachnoid hemorrhage patients, it can be some of the most challenging medical illnesses to take care of in the intensive care unit. These patients are often in extreme high risk for neurologic deterioration, multiple medical complications, and often young, healthy patients who were in the prime of their working lives. But there's nothing more satisfying than taking care of that type of patient all the way through to recovery and seeing that they can return to some quality of life, as long as we can really pay close attention to mitigate the effects of these complications and get them to important proper follow-up care so that we can see them in the clinics and their homes after their complete recovery.
I had the great honor of being the chair of these guidelines. I had previously been an author in the writing group for the previous guidelines that were published in 2012. And in this most recent guidelines, I was able to lead the group and be involved in a very significant way as chair of the writing group.
And in my role, I served as the vice chair supporting Dr. Ho, and as well as working with a team of experts that we selected specifically to become writing group members because they have expertise in all aspects of care of the subarachnoid hemorrhage patient.
This will be especially helpful if you're an emergency room, intensive care unit, or post-ICU doctor or nurse, or if you're a surgeon or an interventionalist. But if you're a healthcare provider of any kind that may encounter someone suffering an aneurysmal subarachnoid hemorrhage, then this is going to be valuable information.
In this episode, we're going to take you through the whole process of the aneurysmal subarachnoid hemorrhage, from the time it happens to the critical first moments after the patient arrives in the emergency room, to the major surgical interventions and treatments that are available, and then as well as going through to the recovery period. All of the possible complications that can happen to a patient in the course of their illness, and absolutely important in terms of their recovery, rehabilitation, and discharge back to their home environment.
This is a complicated process that takes a whole multidisciplinary team with a lot of expertise, and these guidelines can be used to create order sets for dealing with aneurysmal subarachnoid hemorrhage, a game plan that will save lives. And that actually is one of our strong recommendations in this guideline. Develop order sets so you're ready to act quickly and decisively when the time comes.
First, we'll start with some basic facts. Subarachnoid hemorrhage often gets people in their working years with the average age of 55 years. 26% of patients will die before they reach the hospital. An additional 13% will die during their hospitalization. There are three major risk factors for aneurysmal subarachnoid hemorrhage, including smoking, high blood pressure, and family history.
And just to touch on the pathophysiology, when you have an aneurysm rupture, blood fills the outside of the brain, and a number of things can happen. There can be constriction of the arteries, blood clots can form in the brain, people can have seizures, there can be a breakdown of the blood-brain barrier, and you can see elevated intracranial pressure, hydrocephalus, and delayed cerebral ischemia.
So the major goals in treatment is to get the best outcomes for our patients. We need to start treatment quickly, ideally within the first 24 hours of the onset of symptoms. Our goal is to get the bleeding in the brain to stop and repair the ruptured aneurysm. The goal is complete obliteration of the aneurysm so rebleeding doesn't happen. But in cases where that's not possible, at least treating the aneurysmal rupture site so that the patient can be stabilized. In addition, managing the patient in a specialized neurological intensive care unit and monitoring for all of the delayed complications that we mentioned, such as cerebral edema, hydrocephalus, elevated intracranial pressure, delayed cerebral ischemia, and many other complications. We'll go through all of these in more detail.
At this point, we should say that as we go through these guidelines, we'll point out some different levels of recommendations. Class 1 recommendations are those with the highest degree of confidence. They have lots of evidence to support them, and you can feel great about putting them right into your order sets. Class 2 recommendations are a little less sure. They may not have much evidence behind them, but they are still very much worth considering. And Class 3 is the opposite of Class 1. That's something that we can recommend against. Those are things that have been shown to provide no benefit or actually can cause harm. So keep those classifications in mind.
So let's start with the acute evaluation. So when you first encounter a patient, there are some big things to look out for that point to the possibility of an aneurysmal subarachnoid hemorrhage. Patients will very often complain that they've had the worst headache of their life. And it's very common for that headache to come on suddenly within seconds. And we often call that a thunderclap headache. They may also have symptoms such as neck stiffness and pain that causes sensitivity to light. We also know that patients with a family history is a risk factor. So if they can tell you that they've had a family member with an aneurysmal subarachnoid hemorrhage, this could also be a warning sign that that is going on in this patient in front of your eyes. Sometimes patients don't have the classic thunderclap headache, but if they have a headache that is maximal in onset and unremitting, especially if they have a family history, you'll want to continue to diagnose and rule out that as a possibility.
For me, the most important recommendation is to evaluate and treat the patient with aneurysmal subarachnoid hemorrhage as quickly as possible, and to start the treatment quickly, ideally within 24 hours. The worst thing that can happen to a patient with aneurysmal subarachnoid hemorrhage is rebleeding. We know that rebleeding is the leading cause of mortality and morbidity in these patients. So the sooner you can get to the patient, diagnose the subarachnoid hemorrhage, and treatment, that's going to have the most impact on their outcome.
I would agree. And oftentimes, when patients have minimal symptoms and just a severe headache, it's important that those first providers who see that patient think about aneurysmal subarachnoid hemorrhage as a possibility and go through the important steps of getting the history, including family history. And even if the initial head CT imaging may not show evidence of a bleed, the right thing to do in those scenarios is to perform a lumbar puncture and sample the CSF, looking for evidence of occult bleeding, because that can be life-saving in a patient who otherwise may have minimal symptoms but end up returning to the emergency room in much more severe condition.
And we know that headache is very common. So the real diagnostic challenge here is to differentiate that patient that you should be thinking about subarachnoid hemorrhage in versus the very common complaint of headache.
That's correct. Sometimes patients only have a headache and no other neurological symptoms, but we know that if the index of suspicion is high, that aneurysm rupture may be a possibility. Missing that diagnosis can have very dire consequences, and patients who rebleed, as we know, can have double the mortality if that happens before they can get to medical care.
And in these guidelines, we refer to the Ottawa diagnostic algorithm for working up patients with headache and ruling out subarachnoid hemorrhage. And Nerissa, what are those steps in the Ottawa guidelines?
Even in the modern era with excellent imaging availability, subarachnoid hemorrhage is still missed. And applying clinical rules like the Ottawa Subarachnoid Hemorrhage Rule may help providers alert them to patients who might be at higher risk. So the Ottawa rule would say that if a patient is greater than 40 years of age, has neck pain or stiffness, has a witness loss of consciousness, onset of headache during exertion, a thunderclap headache that peaks instantly, and limited neck flexion on examination, any one of these criteria would increase the suspicion for a subarachnoid hemorrhage and would require additional investigation.
It's not just important to diagnose, but to get a quick sense of the severity of the subarachnoid hemorrhage. This is a Class 1 recommendation. That's the strongest recommendation with the highest confidence, that you use clinical scales to determine severity and predict outcomes. The two most commonly used and probably the best scales are the Hunt-Hess scale and the World Federation of Neurological Surgeons grade. And given how serious this condition is, as soon as you suspect, if given some of these indicators, it's time to call in the cavalry. These patients should be evaluated by specialists with endovascular and/or neurosurgical expertise.
Throughout this whole process, blood pressure monitoring is essential. High blood pressures could make the bleeding worse, as well as low blood pressures could really put the brain at risk. So keeping an eye on the hemodynamics and blood pressure are critically important. Also, using medications that are short-acting in order to maintain this balance and avoid blood pressure variability is evidence-based. So for balancing blood pressures, we don't have an exact target, but to really customize this to individual patients and avoiding the variability of blood pressures that can cause harm. We do recommend that using patients who are on anticoagulants should have reversal of these medications, and this should be done as soon as possible. It's more controversial, the use of fibrinolytic therapy, as there have been many studies, but the most recent body of evidence would suggest that these fibrinolytic therapies are not associated with improvement in outcomes. At this point, it's important that these patients with diagnosed or suspected aneurysmal subarachnoid hemorrhage get to a hospital with a comprehensive neurological or stroke center. There is lower mortality and better functional outcomes when patients have access to these facilities, and this is a Class 1 recommendation. So whenever possible, transfer of patients to get them to a dedicated center with neurocritical care, a multidisciplinary team, and physicians with expertise in aneurysm treatment, along with the expert nursing care, can really make a difference in outcomes for these patients.
And that last point is really important because this is a serious condition and these are risky procedures. So balancing the goal of obliterating the aneurysm with the risk of various interventions should be based on an evaluation of the patient and the aneurysm characteristics and should be determined by specialists with expertise in endovascular and surgical treatments. Once you have evaluated the patient using the diagnostic scales we mentioned, that's when you can make decisions about treatment with experts and the family members and loved ones fully informed.
That's right. And now that we've finished this acute evaluation section, we have transferred the patient to a properly equipped and staffed hospital. We'll move on to the next episode to talk about actually obliterating the aneurysm and the complications that come after the aneurysm is treated.
Data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.